And everybody, any questions you have, just wait right for the end.
Is everybody able to see that?
Can everybody see it?
Yes, we can. Thank you.
Okay, great.
I didn't put a lot of lab data in this case presentation, but if there's any lab information that you're interested in having, let me know. I can pull that out of the record as needed. Anyway, I have this individual 49-year-old female who I have known for a few years. She was under my care when I was working in an endocrinology office in Harrisonburg, Virginia, prior to me locating my practice over here in Franklin. And her primary care provider has been at this clinic. So we were able to have continuity of care when she wanted to continue to have me follow her diabetes and her use of an insulin pump. So I wish I could tell you exactly the duration of her diabetes. I know that it existed prior to 2015 when one of my endocrine partners had actually put her on an insulin pump in 2015. And so over the years working with her, I've seen her gaining weight and her insulin requirements have really gone up. And one of our primary quandaries here is how to keep her from gaining more weight, how to help her lose weight, actually, and is there a way to perhaps permit her to be able to use her pump in a more effective manner and a more streamlined process for changing out her cartridges and reservoirs, because she's having to do that every 1.5 days approximately now because of her high insulin use. And so I have, got her on Ozempic. She is interesting in that she has actually had a history of gastroparesis, and we wouldn't normally use a drug like Ozempic in a patient with a history of gastroparesis, but she has said over and over again that it never gives her any kind of nausea or gastroparesis symptoms to be on one of these agents. And so she was interested in doing a trial back with a GLP-1 agent, and we did use Ozempic this most recent time. Is it helping her diabetes control? Is it helping her weight? I don't know that I have a good answer to that, but she was on Jardiance last fall, and due to an A1C rise, her insurance declined to continue to cover Jardiance back in about October of 2019. And so recently we decided, since her A1C had come down to 8%, that maybe we would be able to get an approval from her insurance plan to cover Jardiance or a similar drug. And so she has fairly recently restarted Jardiance, and it is helping to reduce her insulin requirements a bit. So one of my main questions about this woman is, could we use a more concentrated insulin in her insulin pump? And if so, which choice would be best? And will we get insurance to pay for concentrated insulin to help her with her cartridge use and infusion set use? And could it possibly help to lower her insulin requirements because of its difference in, the dynamics of the more concentrated insulin? So I wanted to pick the brains of some of my peers, especially those of you in endocrinology, to see what your experience might be in using something other than U100 insulin in a pump, to see if you would recommend that we pursue such a change. So, I'm open to your questions and eager for your feedback. She does have an elevated C-peptide, so she has an insulin resistance issue and has been on pioglitazone in the past, but she has some cardiomyopathy and issues with edema, and I didn't feel comfortable leaving her on pioglitazone to improve her insulin sensitivity due to those comorbidities.
What is her weight and BMI?
Her BMI is about 44.
Okay.
And she
So,
gained, I don't know if in my history, and if you can find the HPI, I've got the amount of weight that she has gained over the last 3 years. It's about 50 pounds.
so a couple of things on the endocrine side as far as using the tandem pump and that type of thing, and specifically your question on weight gain. So one, you should potentially, make sure at a 50-pound weight gain in the past 3 years that, you know, everyone always thinks they're not eating that much, but that's most of the time the issue is that they actually are eating a lot more than what they think they are eating. So, simple stuff, obviously medical nutrition therapy. I would go along the lines, honestly, of gastric bypass for her. WVU has medical nutrition therapy in one arm and then can lead into gastric bypass in the other. If she's been a diabetic for a number of years, that's probably the only thing that she has left, honestly, to help her lose weight besides to be on some type of, regimen with a person that can, truly get them to follow the diet that's necessary to lose weight. And that would be through medical weight loss. And they can provide drugs that I don't have a clue about. And Ozempic's the best one out there as far as weight loss. And then actually adding Jardiance back, if you could, with her A1C now under 8.5, she actually should be able to get coverage again for it. If they are on Medicare or Medicaid and they don't keep up with their prescriptions, buying them every 3 months, and don't have A1Cs less than 8.5, Medicare or Medicaid will not pay for these drugs. But as soon as they go less than, then they'll kind of pick it back up again. So compliance on the patient's part is huge, but those are your only drugs that are going to provide her weight loss. So there is no other drug option as far as that's concerned. And truly, her weight of 50 pounds, I'd probably do if she's not a smoker, she could do a
She is a
salivary.
smoker.
Okay, then she needs to do a 24-hour free cortisol level. And I just make sure that, she doesn't have some type of hypercortisolism going on, something subclinical. And if she comes back with a slightly high cortisol, then as far as being primary care, I wouldn't even dare touch that. And you just need to send them to us and work that up for you. But asking her about her stretch marks, I mean, if you gain 50 pounds in 3 years, you're probably having some stretch marks, looking for the buffalo hump and the moon face. And, they have some muscle wasting sometimes in their legs. And subclinical hypercortisolism, sometimes they don't really have that many symptoms, but it can be a reason for weight gain and increased insulin resistance, worsening of cholesterol levels as well. So it would be worse with that weight gain to at least think along that line. And he said that she has been referred to go to bariatric surgery, but she's not willing to, or?
Well, she in the past was referred, and she says that she went to WVU and they told her she didn't weigh enough. She wasn't heavy enough to meet criteria. I don't know that I buy that, but
She is now.
yeah, I think she meets it now. Yeah.
Yeah, so she does now. They do need a BMI of greater than, I think it's 32. It's either 30 or 32. It's not that high actually anymore. So, and they have, depending on how long ago that she went, the program now within the past 2 to 3 years is way different than 5 to 6 years ago.
Right.
So, I think that's her only option as far as weight loss at this point, due to her age and drug options. She's going to need professional help to get a BMI out of the 40s. So, as far as using the pump, the tandem and with the Dexcom, she is using control IQ?
Yeah. Yes.
So she can't put any other insulin in it besides that. So that's the only thing, because the control IQ is bolusing her and it's only approved for U100. So she can't put anything else in it.
I know it's off label to use it in any pump, isn't it?
What?
U200 or U500 is off label in any pump.
Correct, but I wouldn't do it in basal
with the
IQ.
control IQ.
Correct, and the control IQ. If she's doing the basal IQ, which is basically that's just it's shutting off on the lows, and
Right.
suspending on lows. You could use it then. And I use, how many units is she on in a day? Do you have it? 200?
Recently, since the Jardiance was added, her daily average has come down to about 140 units a day.
Down to 140. So, I mean, I don't switch them to U500 until they're close over 200 for sure, but most of the time I even wait closer to 250
Okay.
with putting U500 in a pump. And then you have to make sure that you're doing, because it's concentrated on either one of these insulins, that you're doing the correct insulin to carb ratio.
Oh yeah. So a
that you're
good bit
doing
of change that has to be done.
correct. Yeah. So you have to make sure that you're accurately doing those in either one. But that will only help with her pump settings, and she would have to come off of control IQ. I have nobody. I wouldn't do it
Okay.
off labor.
I didn't know if control IQ could be left on. I just had no idea.
What do you mean left on?
Left on with a U500 or U200, but you're saying no, it's
No.
definitely not compatible at all.
No, because it's not it is reading off the blood sugars with the assumption that there's U100 in the pump, and it's brains of the pump, and that sensor teaching the pump on what to do is done on U100.
Okay.
So,
well, you can't get Tandem to hardly explain it because they don't want to even talk about anything other than U100 insulin, and so you have to talk to somebody like yourself who's got a little more savvy with this.
Yeah, I would not. Yeah, I would not even do it. I have U500 in pumps. I don't have any U200s in pumps. I pretty much just struggle with the cartridge and the filling and stuff like that, and the expense that goes along with that until I can get them over to the 500. And then my 500s, I think all mine are actually in Medtronics. I don't think I have anybody in a T-Slim. And T-Slim for our practice is just getting big because of this basal IQ. So kind of leading my next comment as far as what else can you do? She has the smartest system going for her. So if she actually tried to go off of this and just use the basal IQ and not the control IQ, she's going to end up having higher insulin uses. We know with the pump sensors that talk to each other, be it 670G or this basal IQ, Tandem, Dexcom, that this is the way to get the lowest amount of insulin use. Pretty much everybody can drop. Sometimes, I mean, I've seen some crazy numbers, losing, 10 units a day in insulin use, total daily use. And I've even seen up to 30 when patients have been in using this type of a system. So as far as that, I don't think you're going to get better by doing it manually. So I would, probably discourage that. The only thing else is you said a recent initiation of Jardiance at 10. Jardiance doesn't have to be tapered. So you can start at 25. And I would start at 25 unless insurance tells you otherwise, because that's also not correct, but insurance makes us do that. But I try to start it right at 25 so I don't have to go back and ask for reapprovals and all that type of stuff. There is the 10 is really for if you really want a weak dose, and she doesn't need a weak dose, she needs a strong dose. And
I had a Lilly rep tell me a couple of years ago that there was hardly any difference in the efficacy of the 10 and the 25.
Correct.
And that Lilly had questioned whether to even put out a 25 because the 10 was almost as effective. That's what I heard at the time. Maybe that's not really exactly right. But yeah, I planned on taking her up to 25. I just wanted to see how she did. I didn't want to create some side effects or anything because she hadn't been on it for 6 months, 7 months or so.
Yeah, the 10 is really for nephrology or for lower creatinine GFR use. That's otherwise I just start people right at 25.
Okay, good to know.
So and then sometimes insurance likes to balk us on that, but they're incorrect. But we have to do what they say. So those are my few things. If anyone else has something else to add, but those are my few things that I would recommend, from cortisol to probably staying in the same exact insulin until she's up over 200 units, then switching her U500, get her back up to 25 on her Jardiance, and probably get her a medical weight loss group so that she can use other drugs out there to help her lose some weight. And if she loses weight, she will use less insulin.
Yeah,
And
that's right. That helps with this whole cartridge business. Yeah.
Yeah. So, and that's another reason to consider gastric bypass. And we do know that it decreases insulin resistance. These patients lose weight, and she'll probably not be on insulin, but she can definitely decrease our insulin resistance by considering it. And it is a modality. We would encourage it. I would encourage her for sure.
So something more along a Roux-en-Y, not a gastric sleeve.
So it's really up to the surgeon, but in diabetes management, the best results that come are from the Roux-en-Y. Yeah. So the bypass surgery, we see better outcomes for diabetes control and increasing your risk. The other issue, and then the sleeve, obviously, yes, and we do a lot more sleeves than we do gastric bypass because of fear on the patient side when they hear of some of the complications, and then also sometimes the surgeon, just is like, I won't do it on that type of patient. So the other issue is how long she's been a diabetic. So the longer, I just had a patient go and do gastric bypass surgery, and we were just starting her on metformin, and I bet you she won't have any issues. She's off of her metformin and everything, and I bet you she's in her mid-50s, and she'll probably make it for life as long as she can keep her weight off as far as the diabetes. But the longer you're a diabetic and the longer you wait for gastric bypass or sleeve, the less likely you will be successful in being on just simply lifestyle management stuff. So the amount of insulin that she's on, she would need to be very well aware that she would still be on diabetic medications. It's just a matter of how much.
Mm-hmm. Okay. Thank you.
I would add, just as a person who worked in bariatric surgery for 10 years, a sleeve would be contraindicated because of the gastroparesis. It doesn't sound like it's rearing its ugly head right now, but it definitely will when you are essentially turning the stomach into a very high pressure system where it should be a low pressure system. And so that'll cause all kinds of problems, and she won't be happy. I can also tell you that the data long-term for sleeve gastrectomies is just not there. And the weight loss is going to be, she definitely has a better chance of long-term maintenance with a gastric bypass. And it will have the unpleasant side effects of dumping syndrome, which a sleeve won't, but it sounds like she is a carbohydrate enjoyer, and that will curb that, but she definitely does need to be warned about that. I would say that definitely the expectation management is very important for her to be successful.
What if she actually doesn't have gastroparesis and was falsely labeled with gastroparesis? Should we consider a gastric emptying study to look at it at this point?
Well, probably the bariatric surgeon would want to do that anyways, but I'll be honest with you. I've never seen a patient who's been diagnosed with gastroparesis that doesn't have symptoms. So I found that very interesting that you said she has no nausea, vomiting, bloating, all the rest of that. That's pretty unusual.
She's complained about bloating at times, but none of the other. Yeah.
Well, I could complain about that too.
Yeah.
Right. That's pretty common.
I've not been sure about this diagnosis of gastroparesis.
Yeah. I mean, still, I would agree that if it were to me to choose the surgery that I would think would be best for the patient, regardless of gastroparesis, it would be a Roux-en-Y. Even though patients don't always want to hear that, because yes, they are afraid of it, but. Sleeve gastrectomy is not a benign procedure by any means. If you've ever had any of those patients have complications.
Okay, thank you.
Well, Janet, I want to say thank you so much for this case. It's excellent, but really a lot to think about, and everybody's been super engaging and interesting, which I absolutely love. Um, were there any other questions or comments from anybody about this? And Janet, did we sufficiently answer?
Yeah,
Okay,
yeah, I appreciate the insights a
wonderful.
great deal. You've been very helpful.
Great. And thank you so much for the case again, because you're the reason we're here today. We had an email question submitted. I don't actually see the person on the call, but we're sorry, my cat. But uh, we are recording, so she can see it later. Um, and Melissa, I think this ties kind of into today, but also into the didactic you gave last time.
Mhm.
And it's about some guidance on best practice methods for switching patients from one insulin to another. For example, how would you switch a patient with a Humalog mix insulin to just a long-acting basal insulin? And she's a pharm, so I guess she gets asked this quite a lot.
Mhm. So it's total daily dose insulin. So she would need to know how much is she getting, 70/30 total daily. And then most of the time what you do is you take your total daily dose and then you probably make it like a 60/40 spread or a 50/50. And that decision making is probably the hard part because you're looking at um, you know, where they were before. And, sometimes when we do 70/30, it's not always equal on both doses and stuff like that. So sometimes you just have to start to use some of your how they eat and that type of thing. But most of the time it's a split then of 60% of your total daily dose will then turn into your long acting, and then 40% would be your short acting. And anywhere in between you can hedge 55, 45 if you would like to, or 50/50. I get nervous when patients start to swing too much, get too basal, or excuse me, bolus heavy on that, because then patients start to risk lows when they count incorrectly, or they kind of change their meals and stuff like that. So somewhere between 50/50, 60/40. And try not to go bolus heavy. Don't flip it the other direction.
Wonderful, that's super helpful. Does anybody else have any questions, comments, anything?
Melissa, I have a quick question. Can you get Medicaid of West Virginia to pay for U-500 and an insulin pump?
Let me go back to this patient. I think she has private health insurance. I want to say yes, because she already has the pump. So, and they do pay for U-500. So, it's a matter of syringes or vials at that point. So I would say yes. I can't.
I just wondered if they looked at how the insulin was being delivered and would say that's off label to use that in that device. I just didn't know how much they paid attention to how the insulin was being delivered.
Mm-hmm. I don't think so. I think I think you're going to be okay on that. But if you run into that type of problem, call our office and speak with Cherie Bryan, Bryan, and she is definitely the guru of coverage and all the stipulations to go on with the pump. I can honestly say in our practice, that's what is a lifesaver, because I probably deal with, oh my goodness, everybody has a CGM or a pump. I mean, I have so much of that I'm actually impressed you're doing it in your private practice for a patient, because it just seems like that's a lot of what our patient population is now, is just pump management. So Cherie is the person that kind of figures out and answers all those types of questions for us.
And she's within the endocrine department.
Yep,
Okay,
just call her
great.
office and ask to speak to her, and she can give you some better insight on that for sure.
Okay, thank you.
Mm-hmm.
Yeah, Cherie is also one of our hub members that
Mhm.
rotate through, and we can certainly get her on to do an insurance and I don't know, FAQ type thing, because I know we've had a couple of things that we've had to ask her about, so we can always get her back around.
Okay.
All right, guys. I know we have half an hour left, but again, I don't want to keep you. We've had great discussion, a great case, and everything. Any other questions, comments, anything? Let me look at the next day and see what's up. So, our next session is going to fall on July 8th. It looks like we have Dr. Heder talking about appropriate physicals and screenings for endocrine patients. So that should be super interesting. If anybody has any questions or cases, of course, use the case form or email Mitra or myself, and we'll help you out along the way. And I know a couple people jumped on a little bit later, but I'll be uploading this to YouTube shortly, and you'll have the link in your inbox. So everybody have a wonderful day. Thank you all so much, and thank you, Janet, for the great presentation.
Oh, you're
Thank
welcome.
you.
Thank you.
Thank you.